Good afternoon, boa tarde, bem-vindos e bem-vindas. Welcome to the fourth event of Amazonian Futures, Futuros Amazônicos, a series of conversations the Brazil Lab is organizing together with the research initiative Amazônia 2030. My name is João Biehl. I teach anthropology here at Princeton University, and I'm the director of the Brazil Lab at the Princeton Institute for International and Regional Studies. 2 years ago, the Brazil Lab and the High Meadows Environmental Institute hosted a conference exploring the possibilities of an Amazonian leapfrogging, combining conservation and socioeconomic development. We are very happy to have been in close conversation since then with the incredibly important Amazônia 2030 initiative led by environmentalist Beto Verissimo and economist Juliano Assunção. Beto and Juliano have brought together Brazil's most talented interdisciplinary group of environmental scientists, social scientists, and policy experts to produce cutting-edge studies that can inform public debate and interventions aimed at safeguarding the Amazon and ultimately ensuring a just and sustainable development for the region and its diverse peoples. Our event today tackles a most pressing reality: the aging health of the Amazonian population, whose life expectancy is significantly lower than the Brazilian average. Mortality remains high among children, violence and accidents are main causes of death among young adults, and non-communicable diseases are rampant, all amidst a precarious public health infrastructure and difficulty of access to care for indigenous and riverbank communities, a reality made even more acute during the COVID-19 pandemic. We all know that people's health is integral to forest making and sustainable conservation efforts. We are here today with two stellar scholars and public intellectuals to think about the state of health in Amazonia on new evidence and policy challenges. We look forward to their insights on what is happening on the ground and how they see the well-being prospects of this vital planetary nexus. Rudi Rocha is Associate Professor of Economics at the São Paulo School of Business Administration, FGV, and Head of Research of the Instituto de Estudos para Políticas de Saúde, IEPS, a key partner of the Brazil Lab. Rudi's innovative research has appeared in top international journals and focuses on applied econometrics and policy impact evaluation, health economics and demography, and environmental economics. The recipient of multiple honors from the British Academy and the Gates Foundation, for example, Rudi is exploring new frontiers combining quantitative and qualitative research, and we look forward to hearing about new evidence coming from his collaborative Amazonian studies. Welcome back to the Brazil Lab, Rudi. It's a great pleasure to have you with us today. Márcia Castro, who earned her PhD here at Princeton and is also a great friend of the Brazil Lab. Thank you, Márcia, for being back virtually with us, hopefully soon in person. She is the Andelot Professor of Demography and Chair of the Department of Global Health and Population at Harvard's Chan School of Public Health. Márcia is a world-renowned specialist on the geography and the demographic distribution of tropical diseases, particularly malaria in the Brazilian Amazon, and the intersections of socioeconomic status, individual behavior, geography, and health. She's also a columnist for Brazil's major newspaper, Folha de São Paulo, and has been recently named a fellow of the American Association for the Advancement of Science. War congrats, Márcia. We are grateful to Alexandre Mansur and Ana Mello, who lead the communications team of Amazonia 2030, and also to Miqueias Mugi and Rodrigo Simon for their great help in the organization of the Amazonian Future Series. Thank you also to the High Meadows Environmental Institute, the Department of Anthropology, the Department of Spanish and Portuguese, and the Program in Latin American Studies for their co-sponsorship. This is our format today. Rudi will speak for about 15 minutes. Márcia will then have about 10 minutes to offer comments and a few questions to get the discussion going. For the audience watching from home, it's a great pleasure to have you with us today. The chat on our YouTube channel is open, so please feel free to ask questions as the event unfolds. Our team will be collecting your questions and will forward them to me. I will pass them on to our speakers. Thank you all for being here. Rudi, the screen is yours.
Thank you very much, João. Thank you for the invitation, for the introductions. Really a great pleasure to be here with you. I'm grateful to the Brazil lab at Princeton and all our friends from Amazonia 2030. And I'm quite happy to be here with Márcia as well, good friend. It's a pleasure, Márcia. And well, I'm going to share my screen now. I brought a few slides. Hope to go through all of them in about 15 to 20 minutes, 50 minutes. Well, I'm going to present the results of this ongoing project on the state of health in Amazonia. We have been collecting and analyzing indicators of health, access to healthcare, and health policy, and we have discussed during this project health care policies and policy challenges in general. So this is a 2-year project, and we are finally coming to the end of this project. And this is part of Amazonia 2030, and I need to say that it's been I'm quite glad to be part of this initiative, this beautiful and quite important initiative. So this project that I'm going to present now, the results that I'm going to present is part of this health arm of Amazonia 2030. Well, let me start with the motivation. It's quite straightforward. We know that the Brazilian Amazon, the Amazon in general, is the frontier, kind of one of the global frontiers of environmental degradation, but also a place of very high socioeconomic vulnerability. So there are people that live there, more than about 25 million people, and they are typically overrepresented in poverty and in all its dimensions, right? So these people need access to public services, in particular health services, but we know that they face, in general, and policymakers in the field face challenges that are impressive, actually. So this involves lack of resources and extraordinary barriers to action, such as geographical barriers, and just to give you one example of barriers that are related to logistical issues. So, but this is the general wisdom of the situation. What we do here is that, well, we ask what are exactly the needs and the challenges and the priorities of the region in order to overcome these challenges. And when we have a look at the literature, there are very important contributions and quite informative, but in general, the evidence is quite fragmented across case studies that look at very specific contexts. So in this project, our main goal is to provide a comprehensive overview of the situation in the region. And well, more specifically, this project consists of 3 reports. The first one was released last year, December, very recently, and it provides a kind of comprehensive overview, more quantitative, descriptive overview of the situation in the Amazon. We go through many indicators related to population health, access to healthcare services, human and physical resources, financing, governance, and other dimensions of the context. And then we have this second report that is being released this week, I believe. This is the qualitative arm of the project. In this arm, we interviewed more than 30 local actors and stakeholders and collected their perceptions about challenges, priorities, opportunities, etc. So with these 2 arms, we have been able to build up the third report that could be, I think, released still this month with policy recommendations. So what I'm going to do here, I'm going to focus on the first report, and I'm going to give you some results that are coming from the second and third reports, very briefly shown. This slide is just to say that this joint work with my brilliant co-authors, Marcela Camargo, Lucas Falcão, Mariana Silveira, and Gabriela Tomazinho. I have learned a lot with them, especially at the qualitative arm of the project. and also with the data of the region. So these region quarters have helped me in this project, and I'm really thankful to all their efforts and dedication. Well, I don't know if I'm going to have enough time to go through all the tables and figures, etc. So I'm just anticipating a few takeaways, the main messages that I want to mark here. Well, the first one is that when we look at the demand side of the story, what we see is that life expectancy, as a very important marker of health, population health in the Amazon, is moving slowly, and in comparison to the rest of Brazil is lagging behind. Well, we expected some catch up, as we observe across many different places in the world, but still the life expectancy in the region is lagging behind. And well, when we inspect what is going on, there are many drivers of this gap, increasing gap, but especially we have detected this rise in chronic diseases, and this may be leading this increase in the gap between the region and the rest of Brazil in relative terms. So on the demand side of the story, there is this concern that the situation may be getting worse over time with population aging, etc. When we look at the supply side of the story, we observe that the supply of healthcare in terms of facilities, human resources, financing, etc., is quite constrained. Not only constrained, but is still moving really slowly. So on the demand side, we see that the demand needs increasing. On the supply side, it's kind of fixed, constrained. And finally, when we look into drivers of change, and whether local governments, for instance, are able to react and overcome these barriers, what we find in the ground is low state capacity, scarcity in access, and low access to financing, lack of coordination, etc. So this is the combination of the three pieces of the story is quite worrisome. And finally, just to anticipate some policy recommendation that we're still working on that, we highlight that obviously primary care is core here. It is core across the globe, but especially in the Amazon, in remote areas, is quite important. But also I want to highlight that soft inputs are needed. I mean, I'm an economist, and in economics we're used to study production functions of education, health, cars, etc. And then we used to think of labor, capital, technology, etc. And this is needed as well here in terms of healthcare in the region. But what we have collected in the field with interviews is that some more soft inputs are needed, such as management, planning, governance, all of them adapted to the Amazonian context, which is quite unique and heterogeneous, right? So this is, in a nutshell, there's some messages that I wanted to anticipate, and now I can provide you with some evidence that are consistent with the story, right? So starting with the demand side of the story, well, this is very simple. This is just a comparison of life expectancy in the Amazonian states of Brazil with the Brazilian average. This at the left-hand side, and when we look at of course, that we observe that this is a very vulnerable region, and life expectancy is lower. This is expected, but when we look at the changes over time, we still see some difficulties here. So in most states, life expectancy is low, is moving slowly, is lower than in the rest of Brazil. So we expected some catch up again, but still, when we look at very important states such as Pará, Amazonas, and Mato Grosso, life expectancy is increasing only very slowly. So, and then inequality maybe increasing over time in terms of health, right? When we decomposed this distance between average Brazil and average Amazonia to understand what is going on behind this gap. The gap is, this graph just summarize the situation. This dashed line just marks the difference in terms of life expectancy between average Brazil against the Brazilian Amazon. And we see that this is slightly increasing over time, this gap. And when we decompose this number by age groups or cause of death, we observe that is typically part of this gap has been explained by mortality among the elderly, specifically from chronic diseases, but still population is aging, of course, but still we find high mortality among young adults, mainly because of external causes such as violence and accidents, and we still find very high mortality rate among children, specifically related to infectious diseases. So this is a triple burden of diseases, but still with population aging, the situation may be getting worse over time. This is average, right? So comparing averages, but the Amazon is quite heterogeneous. And of course, in our first report, we go into many details, but I just brought this figure that compares mortality rates within the Amazon and a comparison between indigenous mortality among indigenous peoples and the rest of the region, just to show that how heterogeneous the situation is and how bad the situation is, for instance, among the indigenous peoples. For instance, if we compare the infant mortality, this data is quite noisy, so this is just perhaps just a lower bound. But when we look at what is going on with the infant mortality among indigenous peoples, we do find that the infant mortality rate is almost 2 to 3 folds higher in comparison to the infant mortality rate in the region. And it's not only in terms of levels. For me, the striking feature about this figure is that trends remain quite parallel. So we have been not able to close the gap, right? So this is the demand side of the story. This is the situation, and just to give you some facts about the supply side of the story. I start with the coverage of primary care. This is the coverage of the family health program. In Brazil, is a very important community health care program in the country, and population coverage is high, and it is increasing. So, but when we start to look into, and the interviews were quite important to map that. Okay, so let's divide the number of teams, the number of community health agents by area that they need cover. And then if we compare what is going on inside the Amazon with the rest of the country, for instance, among community health agents or the number of primary healthcare teams, we observe that what is going on in the rest of Brazil, well, the numbers, like the indicator, is 10-fold higher than in the Amazon. So there is this relative scarcity of resources when we look more in detail and when we take into consideration area, access, distance, etc. And this is across the board. So this is just a few figures about human resources in general, the number of physicians per capita. It is kind of twofold in Brazil. The Brazilian indicator, in the rest of the country, the number of physicians per capita is twofold what we find in the Amazon. When we look at specialists, is 3-4 times higher. When we look at distances from a given municipality to the closest facility with a given kind of service, for instance, more high complex service such as dialysis, chemotherapy, ICU bed, etc., the situation is still the same. So there is this relative and also absolute scarcity of resources. For instance, if we look at dialysis or ICU beds, what we see here in the Amazon is the average distance from a given municipality to the closest service with ICU bed is about 2 to 3 folds more than twofold what we observe in Brazil. And this is a lower bound again, because we're calculating linear distances. So in the Amazon, distances are also relative. And finally, just to close the relative, the importance of the distances in the region, in the provision of healthcare, we use this PNS, Brazilian PNS, which is the Brazilian DHS survey, the most recent wave, and just to give you an idea of what distances mean in the region. In this question, for instance, we selected all respondents that have either hypertension or diabetes, and they need to see the doctor. And there is a question of, well, are you seeing the doctor? And if they answer no, so why don't you go to the doctor? And when we compare the Amazon against the rest of the country, but we see that the responses among those that live in the Amazon is basically, in relative terms, the service is too distant. When we look at what happens outside the Amazon, people say, okay, I don't go to the doctor because blood pressure is controlled, diabetes is controlled, everything is fine. Of course, everything is in relative terms. And very interesting to see that financial difficulties is not very different across regions. So transportation, distance, access to service, presence of services are quite important here. So this was the demand side of the story, the supply side of the story. And now the question is whether local governments are able to respond to these challenges and improve services and access, etc. And what we find here is that, well, there are huge financing constraints here. So we have SUS in Brazil, the Unified Health System, but there is heterogeneity and inequality in funding, because part of the funding, especially funding to fund primary care, comes from municipality revenues. And of course, municipalities are different, so resources are scarcer in the Amazon, and they rely much more on federal transfers, for instance. On the other hand, they need money and resources because of higher operation costs in the region. So in order to hire a doctor, in order to pay for the maintenance of a boat or transport, you need money, and it's quite expensive to provide health services in the region. So there is this imbalance between needs and sources. The same for, well, there is a need of coordination of efforts across municipalities, and we observe a quite fragmented governance in the region, low state capacity, and huge logistical challenges. So in sum, the challenges are huge, and the capacity that local governments have to respond to that are quite limited, right? This just two slides, and I close my presentation. This is just in the second report we asked interviewees about, okay, what are the best practices, what are the priorities, and what is going on in the field that maybe changing things and improving access to services and quality of services. And basically what we see in the answers is, okay, there are many different things that are important, of course, but management, financing, governance are features that stand out. So this kind of soft inputs are quite relevant in the region in order to make the difference. So just to conclude here, the main takeaways here are, well, basically from the demand side of the story, life expectancy in the Amazon is moving slowly and perhaps lagging behind in many places. Chronic diseases are on the rise, and we still have external infectious causes of death. They remain very high. The main concern here is that population is aging. The supply of healthcare remains constrained. We observe persistent barriers to reaction at the local level. So we expect more inequality in the future, right? So some policy recommendations here, just a very quick overview. First, soft inputs are needed in terms of management, planning, governance, adapted to the context, to the Amazonian context. More funding and resources, but perhaps used as a device for policy coordination and good governance across local governments. And primary care, again, is absolutely core, especially in remote areas, right? So I'm just conclude with this final bullet. We have been thinking about how to deliver healthcare at extreme conditions, right? So this is challenging. So, and this is just a motivation for those that are listening to us. Perhaps if we solve this Amazonian puzzle, we are able to solve any puzzles in terms of access and provision of healthcare across the globe, right? So, thank you very much, João.
Thank you so much, Rudi, and it's and I cannot imagine anyone more, competent and visionary to help us with this puzzle than Márcia Castro, who has worked on tropical diseases and her work has focused on the question also of geography, individual, collective health, and governance in the region and comparatively as well. So Márcia, we want to hear from you now. Thank you so much, Rudi.
Thank you. So first of all, it's always a great pleasure to be back to Princeton and to the Brazil Lab, even if remotely. And thanks, João, for your very kind introduction and your words. So I want to start by really congratulating you, Rudi, and all the team that work with you doing this really, really massive effort of putting those reports together. I've seen 2 of them, and it's not an easy task. And I really want to congratulate all of you for putting this together. So I'm going to make three comments broadly, and this should get us going into some discussion. So the first one is the context you presented to us is really the basis of starting to talk about syndemics in the Amazon, which is truly what we have. We don't have epidemics, we don't have pandemics, we have a syndemic. And what that means is that the environmental conditions, the political decisions, the socioeconomic conditions create a scenario where you have multiple epidemics, multiple diseases occurring, and they interact with each other. So you have this synergy epidemics that actually the end result is that the sum of the consequences of the multiple diseases is much more than if you had them individually happening. So one makes the other worse. And that's exactly what we have, right? So you have the environmental conditions that make malaria much worse, that create the ideal conditions for dengue to spread. Dengue is everywhere in the Amazon now. It wasn't if you look 10 years ago. So this scenario that you portray to us is the basis of a syndemic scenario that basically means that if you really want to address this, your interventions, your decisions, your policies have to be comprehensive. Just health won't get you there. It has to be much more than that. So the roots of the problems creating this context of a syndemic must be addressed. Otherwise, we're trying to dry ice. It's never going to happen. So that's one point for us to think about. Exactly because of that, we see the consequences of COVID. And you presented to us how the gains in life expectancy at birth in the Amazon are happening, but are very slow, much lower than in other areas. So there are gains, but they happen in a slower pace. Well, you presented the scenario to us until 2019. Here comes 2020, and the largest declines in life expectancy at birth because of the pandemic happened exactly among the states that are in the Amazon region. Just to give you one example, if Brazil lost 1.3 years, Amazonas, whose capital is Manaus, that was all over the news, right, lost 3.5 years. Okay, and this is 2020. It's even worse in 2021. So if you look how much Manaus gained in 2 decades from 2000 to what it was expected to be in 2020 without the pandemic, it lost 60% of this gain in 1 year. This is 2020. Again, to 2021, the picture is even worse. So here you are describing a scenario that is really worrisome, right? That, as you called, it's a puzzle. How do we solve this? And now it's even worse. If it was a puzzle, now it's this super duper puzzle, and how you can even address those issues that became much more exacerbated by the pandemic. And we know any pandemic, any epidemic illuminate inequalities. But here, my goodness, you illuminate everything and just made it worse, okay? And that brings me to the third comment, which is, I honestly think, and I'm gonna try to challenge all of you guys to think about the third report, which is the policy recommendation, right? The policies can't be just about health. It can't be. And honestly, the root of the problems, if you go, everything you see that's happening in the Amazon now, the combination of diseases that we have, the challenges we have, they are right there in the development model that we have for the Amazon. Since the, you go back to the rubber booms that we had. So this goes all the way back in the end of 19th century. And the model for the Amazon has always been a model, the so-called development model, right? We can question that as well, but it's a model of exploitation. Let's take the resources, you ignore the needs of the local population. Above all, you ignore their knowledge, you ignore their voices. So basically the local population is completely ignored. And I mean, let's say the extreme example of ignoring the population is in the middle of the military government, right? 1972, Medici was the president when he said the famous thing, let's give land without man to man without land. So you cannot go more clear than that they completely ignore the local population. So to me, for a health policy or whatever policy you're talking about to really work, to have a chance, first, we need to change this view that to develop the Amazon, you need to get rid of the forest, or you need to remove all the resources, and that's the only way to develop. We have plenty of examples now that you can make agriculture to be extremely productive without increasing the deforested area. And I think on that, the work of MAP Biomas, which I know it's a very good friend of Brazil Lab as well, has demonstrated this for 30-something years of data. The other thing is, when we think about health per se, how can we actually incorporate the local knowledge and the local voices in those health responses? And here, the indigenous community is particularly important, right? I mean, how much we really stop to listen what people are doing that can be highly affected, and we just ignore. And the question is, how can we also use this as a way to get better data on the indigenous communities? You mentioned this in the report. So can we actually leverage their knowledge, empower their voices, and through that, we create a mechanism to have better data without being invasive, without being disrespectful, and respecting their culture. At some point in the past, we used to have indigenous people as community health agents, just like we used to have a special type of agent for people working on the countryside. And all of this belonged to a particular department in the Ministry of Health that is gone under this government. So, but to me, that's critical. It's like bringing diversity and inclusion to the policies that you're doing in the Amazon. And if you don't do this, I'm sorry, I don't think we have a chance to break this puzzle, right? And the last thing I'll say is, there's this say that says, if there's a will, there's a way. And I think that's absolutely true. And we know, at least hopefully until the end of this year, we don't have a way. because there's no will, right? So I think the question that we need to challenge ourselves is, what can we do under a completely adverse scenario where we know the actions are not going to come from the top, will not have support from the top, but we cannot wait until, we have another person sitting in Brasília to then support those actions. So I'm not pretending to have the answer. I don't think I have, but I think we need to have this dialogue, and particularly with this in mind, that we need to think of the local people, their knowledge, their voices, and as much as we can try to get rid of this developmental policy that it has only brought horrible things to the Amazon. At least that's how I see it. So I'll stop there. And I think there's plenty to discuss.
Yeah, thank you so much, Márcia, for your probing and visionary comments. So, Rudi, do you want to tackle some of the questions, probings that Márcia brought up, and then we'll have a few questions already from the audience, and then I will pose them to you both. But let's hear from you, Rudi.
João, Márcia, thank you very, very, very much. Well, I thought, João, that we had a puzzle. I think it's much worse, right? So Márcia just made things worse, because it is true, of course, that we need a different development model in the region. So and everything is connected, right? So, but it is also true that we need to think, for some regions of Brazil, we need to think of a different, what called federal pact, right? Because sometimes we don't need to, we won't wait Brasília to move. Otherwise, we need to have local, more resilient health systems and so on. So, what would be the perfect federal pact for the Amazon? And perhaps it's different of what we should have for the other regions of Brazil, right? I believe that in the Amazon, the local governments need help, not only with resources, but with coordination. And if this is not coming from Brasília, perhaps from the state governance, and in order to induce more coordination, governance, not only in health, but perhaps connecting social policies in general, because if a boat can deliver healthcare, it could also deliver social assistance, education, labor market policies, etc., etc. So coordination could be could be thought in a more comprehensive way as well, not only across governments, but also within governments, across different social areas, right? So, maybe this is a way of try to answer your last question, right? Your what can we do if we don't have Brasília, right? I still believe that we do have states and municipalities, and they can work together. In education, we do see that infant education is responsibility of municipalities in Brazil in general, but we do see in the Amazon states providing directly more basic education, because municipalities don't have resources or state capacity to provide that. Perhaps in health is not only the same, but the situation is much more relevant, because we need scale, we need coordination, we need efficiency, we need health regions working together to deliver healthcare in a more integrated way. So this is a way of think about the case. So that's why I believe that coordination and governance is particularly important in the region. How to incorporate local voices? I think that in the field we do observe that this question is alive. It's challenging, but among the best practice that we have heard about, this is happening, but we need regulation and we need incentives, and for that to happen in a more comprehensive way. And finally, in terms of the syndemics, well, this is, if we think positively about that, perhaps we can solve all of them together through a new development model, for instance, because as you said, if you have a problem here, you kind of generate other problems, for instance, dengue, as you mentioned. Perhaps if we solve the puzzle, we're able to tackle all these issues at large, right? So, but still, I'm going to think about that and try to incorporate some insights in the final report. Thank you very much.
Okay. So let's continue the conversation. We have a lively set of questions coming from the audience, from João Moreira Salles, and I think this goes first to Márcia. Are there any lessons to be learned from other Amazonian countries, or even from other tropical areas in the world? So it's a comparative question of best practices when it comes to the field of health. Márcia, do you want to get going with that?
Sure, it's a great question. So if you think, for example, Peru, I mean, I do some work in Peru related to malaria. They face the same challenges. One difference is that most of the areas that face health challenges are all riverine communities. And those communities don't have a lot of support from the government. They all have to travel across the rivers. So one of the key challenges there is not so much support in the deforestation that happens around those areas. So the challenge of deforestation are pretty much the same. They have a period of 5 or so years when transmission really came down. It was a massive effort from the government at the time. They had distribution of net. They have a really intense and comprehensive way of addressing malaria, but it all came back. They stopped the program suddenly and it all came back. Not so much examples from Venezuela in the recent past. I don't know much about Colombia. So, I mean, broadly, the challenges are similar. Now we have the challenge of gold mining. Illegal gold mining is all over. It's destroying Peru. It's destroying Brazil. It all goes through this lack of regulation. And in fact, in Brazil, it's relaxing the regulations we had. It's just completely obscene what's happening. There is a new report that just showed that last year, from January 2019 to July 2021, only 2% of the areas that had alarm of deforestation, 2% had any follow-up from the federal government. That's nothing. So nothing happened with the others. So I think we have some isolated examples, small-scale examples that involve some local communities, but it raises the question, can they be scaled up and they can be sustainable? I don't think we have a demonstration without real support from the government that those things can be scaled up and sustained. So we had a very good period in Brazil when deforestation rates are going down, malaria was going down, reached the lowest level in 35 years. Everything was looking okay. We still had problems, but there was progress. Gone. And this happened in 2016, that it was increased exactly at the time when we had the austerity measures. We reduced mais médicos and everything happened around the same time. And from then on, it's been downhill. And I wish I had a better answer, but
yes, no. It comes back to that to the question of the development model and the political question, right? And the question then of governance that Rudi was posing. And along those lines, you just mentioned the mais médicos, right? Rodrigo Simon asked Professor Rudi, as you said, that primary care is absolutely core in remote areas. I wonder if it would be important to maintain or bring back a program such as Mais Médicos. So the question is, what some kind of concrete initiatives that prove to have had some purchase, some force, could they be brought back? Could they be integrated again in interventions? And then a question that resonates with the point about development model. a kind of like a coloniality model also in thinking about development within Brazil. Maria Luisa Lucas asks, Rudi, thinking about the heterogeneous context of the Amazon that you mentioned, do you believe the application of health management models based in the South or Southeast play a negative role there? For example, which model would be necessary to overcome the difficulties of access or the lack of training of professionals to deal with indigenous communities? So it's the very mentality, the very training, the very thinking about care delivery that has to be decolonized, so to speak.
Thank you, João, and great questions. Actually, well, we do observe that during the some years ago, an important share of doctors in the field in the Amazon came from the Médicos program. In many municipalities, we observed that 100% of the physicians in the field were from the Mais Médicos. So this is a strategy, very important one. I think that this is an option, and we could resume the program with more incentives. This is an option for sure. But still, when I showed you a table of best practices, the first two rows was about management and governance, etc. And the third leading factor that was mentioned by local actors, stakeholders, was how do we we attract and retain human resources and doctors in the field in remote areas. So this is priority for sure, and we should try with very different strategies actually. So we should design. We discussed a bit of that in the third report. We should design specific training programs which could attract young doctors to the region, and which could incentivize these inflows of doctors to the region for sure, and partnership with local universities and so on. So we should think of different strategies to attract and retain professionals in the field. And it is also important to say that while we do observe that the number of physicians per capita, for instance, in the Amazon, in comparison to the rest of Brazil, is lagging much behind, this is not happening with nurses. So the number of nurses per capita is catching up with the rest of Brazil, and they're quite important in the region. The same for community health agents. Márcia mentioned indigenous health agents, which are quite important in the region. So we need a very more comprehensive view of how to deal, attract, and train human resources in the region. So I think this is quite important. Mais Médicos is important as well, right? And Maria Luisa, this is a quite important question, and well, what we have heard from the interviews that yes, we need help, but they need to come here and understand what is going on in the field. So because the problems are kind of unique, and so we need to teach them as well how things work here. Yeah, but we need help, right? We need resources, we need information technologies, and etc. But I think that both sides could learn with each other in order to create this continuous training program, so that not only targeted at health professionals, but especially targeted at policymakers and local public servants as well. So I think this is more complex than it's in that first side.
Can I make a quick comment? Just to make it clear, the government created another program to, in theory, replace Mais Médicos. It's called Médicos pelo Brasil. It was created in 2019. The first call for applications only happened now, so 2 years afterwards. And while Mais Médicos had around 17,000 physicians, this call, I don't remember if it's 3,000 or 4,000, so it's ridiculous, right? And the moment Mais Médicos was over, 70%, of the coverage of indigenous communities was gone from one day to the other, right? I like an idea, and some people may think I'm a communist for saying that, but I don't care. Some of you may remember Projeto Rondon. The younger people won't remember. Projeto Rondon was an idea that you are in university and then you take some time off, 6 months or whatever, and you go somewhere in Brazil and you're going to do some work. I honestly think everybody that goes to a public university had to do 6 months of this, whatever name it is. But not like if you study in the medical school in São Paulo, you're not going to go to Ribeirão Preto. No. You're going to go to the places that need your knowledge, need your help. And that gives you a chance to actually become more of a Brazilian and learn about Brazil. Because people don't know what the Amazon is. They don't know what the semi-arid in the Northeast are. That would give a chance for people to grow up as persons, honestly, but also would bring younger people that, who knows, maybe some of those would be attracted to work with those communities. So I really think this should happen. The last thing I want to say quickly, to decolonize, a lot of people are using those words, but we have to listen to the population going through the problems, because nobody knows better what are the challenges, the barriers, the bottlenecks than those people there. We just went through a massive work with the WHO called Rethinking Malaria. And one of the cornerstones of all this work is you better listen to people before you land anywhere and say, we're going to do X, Y, and Z. You have no idea what you're talking about. And that's the problem that happens in the Amazon, that happens in the Northeast. People come with the solutions, but they don't take the time to learn what the problem is. Mm-hmm. And that is, you are set to fail from the beginning.
So continuing on that, like I want to get back to following that line of thought, Márcia. I want to get back to what your first set of comments about the syndemic scenarios. And I want to bring then Rudi back into the syndemic scenario about this explosion of chronic diseases in the Amazon, right? So what have you learned, or are there studies, how does that explosion of communicable chronic diseases fits with this syndemic scenario that Márcia probed us, linked to development models, failed policies, as you yourself said, lack of resources and investments, but also, food industry, change of habits, food cooking patterns, new industries, new markets, So bringing back this syndemic scenario, how do you see that explosion, and what a certain knowledge from that perspective, how would that change how we would envision care, delivery of care? Rudi, do you want to get started?
I was hoping that difficult one was for Márcia. Okay. I think, João, that COVID is a very good example, right? So it's an infectious disease that hits very hard, very vulnerable population in terms of income, poverty, etc. But it hits as well harder people with comorbid, with chronic diseases and the elderly, right? So all is connected to as Márcia mentioned, once you have a problem, you just go and trigger many others. And you have mentioned briefly habits, food consumption, and many other dimensions that are instrumental for health, right? So, and we know from surveys and etc. that yes, people that are overrepresented in poverty are also the people that access diets that are poor in many nutrients and so everything is connected, right? So how to change that? Well, again, I leave it to Márcia. Again, I would leave it to Márcia. But yes, I think that once we have a different development model in general, and once we have vectors of change, for instance, and at schools, where we can change it gradually and perhaps mitigate general impacts such as those triggered by all this massive endemic context, right? So,
Márcia, do you want to add something about that? You know, from drawing from your expertise in malaria, now thinking through this explosion of communicable diseases in the Amazon.
Yeah, so a couple things. One is in one of the areas that we worked many years in the Amazon, it was just crazy to see that sometimes the person had a fruit tree on the back of the house and the trees would go bad and they wouldn't eat it, but they would buy that horrible thing, tangy, whatever the name was, and make juice from there. That's the pressure of the market, right? It's cool to eat that juice. I mean, if you can call that juice, instead of eating the fruit. So there's one thing, it's this influence, it's this heavy influence of the market of the ultra processed food, which is very heavy. I mean, again, if you go back in the 60s, it destroyed breastfeeding in Brazil, Nestle, right? With the powdered milk. So that influence is extremely powerful. And again, we see more and more groups promoting the healthy eating from the Amazon. You don't have to do anything new. The food is there. But you need more of this. Again, it's more of valuing the local knowledge and making the local knowledge to be really the right thing and not having to adopt other behaviors as being the right thing. And one thing about this endemic is that, take malaria, things accumulate over time, right? So you start with the deforestation. If you do have gold mining, it's malaria, it's HIV, prostitution, violence, homicides. It's a chain of events. And then suddenly when you have this new urban area, there is dengue, and there's a bunch of other diseases. So that's what I mean about trying to address the root causes, and the point that to really address the issue of endemic, you have to look at the social, you have to look, so the policies have to be more comprehensive. The final thing I want to mention is, we've seen this before, João. If you read the reports of 1910 from Oswaldo Cruz and Carlos Chagas, which they're masterpiece, honestly, they describe the situation in the Amazon where people were sick, they couldn't work. And at that time, we had eugenics, they would call them lazy. We don't have to talk about this, but the point is they brought back this report, and the government at that time understood that those were not just health issues, they were social and economic issues. And if you didn't address them, you would never promote the development of the country. We need to go back to this time when those issues were seen as social problems, as economic problems, basically the understanding that if you don't address those, you're harming human capital, you're harming the development of the country. And we are not there yet. We've been through this. And unfortunately, those are health issues. Oh, those are like vulnerable people. It doesn't even make the headlines, whatever happens in the Amazon. So if we don't switch this,
Well, yeah. So I think one of the questions that we had follows this line of thought as well. And maybe to Rudi too, it's a question of, you talked about, this different forms of governance, this soft form of interventions, right? So people ask you to unpack a little bit more, but against the context of COVID, for example. Lucas Prati said, in terms of healthcare, we saw awful scenes coming from the Amazon during the pandemic. Have politicians done something after the tragedy? Or most likely not, but like, where do we draw sources, if not of inspiration or models of sorts, for that kind of adaptive, soft interventions that are needed? I think that's one set of questions. And one question that I have, and I will preamble that, I know we are coming close to the end, we have a bit 5-10 minutes still, but I was teaching today medical anthropology, and we were talking about medical errors. We were talking about the third biggest cause of death in the United States, after cardiac and at least according to studies from 2016 from Johns Hopkins, after cardiac disease and cancer, medical errors. And then we heard a colleague of yours, Márcia, from Harvard, Atul Gawande, incredible neurosurgeon and physician and writer physician, and he said that he was always bothered by the high number of deaths in surgery, through surgery, as one form of medical error. And then he said, where do we look for ways to learn how to, quote unquote, fix that? Because it's not a matter of just more knowledge. There's incredible knowledge already. There's incredible technology, but the system got so complex. So how could we then take care of the errors that come from the added complexity to the system? And then he said, well, we had to learn from industry that deal with complex issues like aviation, for example. So how could, then he came up, and one of the things that he learned from the aviation industry is the checklist. He said, here I am looking for a high-tech solution when the solution is a low-hanging fruit, like they have this incredible checklist, but the checklist is then linked to a certain culture of procedures, teamwork, and he didn't see that as part of the culture of biomedicine, some humility, learning other people, et cetera, and they applied that checklist, simple things around the world, and they were able to eliminate 40% of deaths due to medical errors in surgery. Long story short, there's something very powerful in your message about adapting primary care to the Amazonia's heterogeneous context and looking for these soft, interventions that go beyond capital, labor, and technology, more technocratic approaches. So the question then is like, where do we go for inspiration then? Are there other sites in which that kind of soft power has been activated, other problems, that could work as an inspiration for thinking of alternative ways of intervening? Or does inspiration come, as Márcia suggests, from what has been done in the past, has worked and has not worked, right? Or anyway, so I think people are curious if you could add a little bit more of a specificity of that soft interventions, right? And maybe we can ask on Márcia as well to come in and discuss that. So the first question is, has COVID-19 teach the politicians something, right? And what would that be if it happened? And if not, what could it be? Learn from that. And then thinking a little bit about this more in concrete terms and comparative terms, this soft kind of interventions.
Well, I believe that, as we say in economics, management is kind of everything actually, but it's quite endogenous, right? So this is determined by many multiple factors and restricted by others. And this is the same for this kind of soft inputs, right? Such as management and coordination, etc. That's why I believe that we need some top-down incentives to make it work, not in this colonized way as framed before, but in terms of financial incentives that could induce collaboration and coordination, experience change, training, and etc. Right. So I do believe that this kind of technology, soft technology diffusion, is possible if we design good contracts. When I say contracts, it's all about how to make people collaborate, how we make like municipalities to work together, and together with the state government and with the Ministry of Health and etc. So I do believe that contracts can make a difference, especially if it comes with resources, financial resources. So I think that we saw that in PSF, in the Family Health Program. So the Family Health Program took off in 1998 onwards, when the program started to be more heavily funded by the federal government, right? So, and the federal government designed the contract. Okay, you need to deliver that. You need to invest with your own resources on facilities, etc., etc. And this is the guidelines, right? You can opt in or not, but it was when the program started to work and expanded across the country, right? So you design the guidelines and the contract, and you give training and funding, right? I think that we could do the same to induce coordination, not only in the Amazon, but in the rest of Brazil. We know that the health regions don't work very well in the country, and we need them, especially in the Amazon, where we do need coordination, because the challenges are huge and are common across borders, right? So I do believe that we can think of contracts to make it happen, but we need that to come, these contracts and the funding to come top down, maybe from states, maybe from the federal government, but we need something to leverage to coordination in general. So spontaneously, endogenously, I don't think it's going to happen, as it hasn't happened, right? So, and COVID, if people have learned with COVID, I really don't know, João. Yes, we have learned a lot, and I do see many local public servants and policymakers doing a great job in learning a lot, but still, I really don't know that this kind of soft skills that we have acquired through the pandemic, we are going to use that, and well, you know that in every 4 years everything changes in Brazil, either at the local level or at the federal level, and this is something that we collected in the report, right? So the turnover of politicians and public servants, etc., it's a massive problem, not only in health but across all areas, right? So I think I said I talked too much about the medical errors and aviation, etc. This is a great question that maybe Márcia is able to to deliver that. So
thank you, Rudi. Thank you, Márcia. Do you have some comments?
So yeah, so the first one about about COVID, and I mean, if there's anything that the pandemic has taught us, is that, you know, that there's no amount of technology that can save us from poor governance. And that's not just Brazil. We have plenty of examples. And probably the most starking example is the US, that had a change in governance in the middle, and it was, you know, from water to wine, honestly. So so that's the main point. And it's fascinating to see all this literature we had on resilience of health systems. And I'm like, forget about all of that. I mean, all you need is bad governance and everything goes downhill. So that's one thing. You know, I think we should look at what happens in Costa Rica. Costa Rica is a tiny country, right? It has one of the highest life expectancies in Latin America. How the heck do they do this? With local people that go, it's the barefoot doctor, right? The old expression of the barefoot doctor. They go house by house. It's prevention. And they managed to have the highest life expectancy in the entire region. It looks like the community health agent, but it's cheaper than that. It's people really committed that go house by house. Of course, it's a much smaller country than Brazil. Brazil, everything is worse because it's much bigger. But the essence of the idea is the same. It's prevention. We spend so much money dealing with the consequences of not focusing on prevention. We are always going after the houses burning, but we do a lousy job in preventing the houses from burning, catching fire in the first place. So honestly, it has to go through prevention. It has to go through strengthening primary care, but real prevention. And I think, as Rudi just said, at some point, the family health strategy was working. It brought down massive, inequalities and improved indicators. It was extremely important, but it didn't grow as it should. It didn't, and even worse, it shrank. It shrank. So now we're seeing some indicators going up. But honestly, we don't need the fancy technology. We don't need the rocket science. No, it's the simplest thing. It's caring about people. It's delivering primary care. It's focusing on prevention. And above all, not having the same solution for all Brazil, because the truth is Brazil is very different. And maybe what you're going to do in the Amazon is adapted to the local culture, adapted to the local food or whatever it is. But the essence has to be the same. It has to be prevention. We don't do that well. And we're so much worried with tertiary care, specialized care, but we should be worrying with primary care. So we are going to have less demand for the tertiary care. So look at what we have in Brazil. We have 20% of the population obese, right? 55 or something overweight. That's a ticking bomb. Who is going to pay for all the chronic diseases we're going to have in the future? Not the public care, not the private care. Nobody's going to pay for all of this. How do you fix this, or at least try to tackle this? It has to be with prevention, changing behaviors, especially in the city, right? And we're really missing the train on that.
So I think thank you so much, Rudi and Márcia. We have a final set of questions. We are coming close to the ending of this, fascinating and really thought-provoking and energizing, conversation, because you guys are clearing the field for vision to come in and as you said, less technology and more like listening, engagement, and a different kind of incentive for a different kind of politics of health to emerge. And these two questions are fascinating. The last one is from Robert Davenport, who says, how can the past successes of SUS, largest public health service in the world, be better recognized, be better publicized, so to speak, as the COVID tragedy in Amazonia is almost entirely political, and the impact is for indigenous communities. So it's the question of maximizing the story, the successes of SUS, and the relevance of SUS, right? And the other question goes in line with where we are at the Brazil Lab too. We're just starting a new research hub on engaging indigenous ecologies of knowledges, and Fabio Zucker asked a question that was already at the core of initial set of comments that Márcia made, and then Rudi also presented data on indigenous communities and responded to Márcia's concerns. In practical terms, what possibilities are there to consider combine indigenous knowledges, both in etiology and treatments of this endemic situation of chronic and infectious diseases? Right? So we don't assume that you will both answer these questions, but we would love to have them as the final prompts for you to pick any aspect of this last set of questions that you would like to share some thoughts about. And then why don't we start with you, Márcia, and then we hear from Rudi, and we hope to continue the conversation, among ourselves and a new fora here at the Brazil Lab.
Okay. So the first question is a great question. And honestly, we are seeing this now. I mean, the number of people showing up to get a vaccine, holding signs, Viva SUS, and really, really highlighting the importance of the health system has been amazing. And some of those people were the people that either completely ignored SUS or only said bad things. And one of the reasons is the media focus on the bad things. The media focus on people lying on the floor, waiting on the line. And so I think we are starting to see a change where people are recognize the important role that the health system plays. I hope this will continue and will expand further so people recognize that without SUS, we would have about 3/4 of the Brazilian population without any kind of healthcare. So it's happening. The more each one of us can do, so we that are writing about this and the media can highlight, the better. We cannot lose this momentum. So that's one thing. And I think we have plenty of examples to show the difference that SUS makes. So we need to to value this and to put this out for the people to understand. So the other one was, oh, I forgot, what was it was the most complicated one. It was you were on mute.
How to actually...
the voices, yeah.
Concrete terms, how to engage that, both in the and the treatment.
Yeah, so I think there are already some local initiatives doing this. Recently, we had the first Indigenous person receiving a degree in anthropology in the Federal University of Amazonas. And I forgot his name now, I'm sorry, but he has been terrific in bringing the knowledge of local treatments, a completely different perspective of how you see an infectious disease. And I'm not suggesting that this is going to completely change how we do medicine, but it's recognizing that there are other ways of perceiving the disease, of approaching the disease. And sometimes what you need is not a pill. It's not always the case. This is particularly the case for mental health. And I'm really happy to see how more and more community-based mental health care is being provided without a single pill, but it's about listening, it's about community support, peer support, and this is that's a good thing that is already happening. It's a completely different view of how you deliver mental care. So it has to start small. I honestly think that you're not gonna make this inclusion, this bringing the voices from a national policy, forget it. It's not gonna work like this. It has to be organic. It's gonna start from some groups, and hopefully it's going to gain momentum. And why do I believe this? Look, folks, the family health strategy started because of an initiative in Ceará that had the highest infant mortality rates in the 80s in Brazil. And they started doing this modeled in whatever is the barefoot doctors in China and what they did in Cuba. They created this model of the community health agent. They brought down infant mortality. Then they won an award from UNICEF for doing this. And they were the inspiration for creating a national program, which was the family health strategy. So I may be totally naive and a dreamer, but I really believe in things happening organic, locally, getting momentum. Here's the example. Of course, you need a government that supports, but I still believe that should be the way, but I don't know.
Yes. Dito, share the same thought. Thank you, Márcia, for voicing it that way. Rudi.
You may say I'm a dreamer, but I'm not the only one. So
for sure.
For sure, right, Rudi?
For sure. Well, I start with the question by Fabio. Fabio, which is I'm just thinking about that. I have a concern that, chronic diseases are on the rise, not only in Brazil, but among the indigenous peoples as well. And in general, they don't have the traditional expertise to deal with this new thing. So this really, really worrisome, right? So we need to deal with that. We need to treat the situation in a very, very integrated way and listening to them. So, but this is just a peel of concern that I add to the discussion, right? And I agree totally with Márcia for sure. Regarding Robert's question, I think, Robert, that people in general hate health systems, right? Because across the world, right? There are exceptions. There is some NHS fraud, etc. But in general, they are always complaining about health services and etc. And health systems are complex. They're really hard to understand. They're not like an educational system, which is straightforward, right? So it's different, so it's hard to understand. So and it's quite difficult to put your health system from your country into perspective and to understand how it works and how good it is in comparison to other places, right? So I agree with Márcia that COVID put health systems into perspective, and people started to think here in Brazil that, okay, so it's not just about very crowded ER. So it's about vaccines, surveillance. It's about so many different things that affect our lives, right? So, and many things work because of SUS. So people start to think about that, and I think that COVID was really important. And every time that I have the opportunity to say what SUS delivers each year, I use the opportunity to highlight the challenges. So every year, SUS delivers more than 10 million hospital admissions per year. This is almost 2x the population of Denmark, right? So we have 2 summers and 2 winters each year with malaria, dengue, and diabetes, violence, and SUS has to deal with all of that, right? Every year there are 2 million births in Brazil, most part of the births in SUS. There are more than 1 billion ambulatory procedures each year. 1 billion, this is massive, and with scarce resources. So when we observe what we did in terms of life expectancy, as Márcia mentioned, the Costa Rica case, in Brazil, with the resources that we put in SUS, I think we have actually advanced a lot. So thank you, Robert, for just flagging this answer and for giving us the opportunity to tell more about SUS and to make it through the public opinion, etc. So this is quite important.
Thank you. No, we are incredibly grateful to you, Rudi and Márcia, for your presentations, comments, and probing thinking. And I as I was hearing you throughout, I was in my mind, Georges Canguilhem's words that health is not being normal, health is being normative. They were resonating in my mind, and I think Rudi and Márcia, you helped us to see that primary care, healthcare, has to be adaptive too, has to adapt to heterogeneity, to diversity, has to be attuned to history, to the political. So health as adaptation, but healthcare as adaptation as well is one of the major points that I leave the conversation here with, and many, many more questions. So thank you so much, Rudi and Márcia, for the time with us and for your wisdom and your care and vision. So for our viewers, thank you for watching. We hope you will be here with us for future Brazil Lab events. Please subscribe to our YouTube channel. Next week, on February 10th, 4:30 Eastern Time, 6:30 p.m. Brazil time, we will be hosting a timely and important discussion on systemic racism and the social impact of affirmative action policies in Brazil with legal scholar and law professor Silvio Almeida, Princeton sociologist Fred Worry, and our own Brazil Lab Associate Director, economist Thomas Fujiwara. Stay well and see you all soon. Thank you for being with us.